Good afternoon, everyone, and thank you, Dr. Ritu, for this opportunity. I think it's perhaps not an overstatement to say that cataract is one of the most common refractive surgeries these days, and every single cataract surgeon is now aiming that to make their patients as spectacle less dependent as possible. So I'm just going to put up my slides now, and as they say, if you begin well, then it's half a job done. So let's start by preoperative workup in the premium IOL patients. So it's not just about 20/20, but it's also about giving them distance, intermediate, and near vision at all points in time. So apart from the standard pre-op cataract workup, which you all know, a detailed history about which I'll be talking about subsequently is very important. What all to look on slit lamp, how to make a note of pupil size, because all said and done, we still have some premium press biopic IOLs which are pupil dependent, whether they'll accept EDOF, how much of their diffractive rings will be exposed. So we need to look at that. I'll also be talking briefly on how to refine your existing biometry to get the best out of your premium IOLs. A pre-op imaging system, if you have video on to how to do that. Corneal tomography becomes a very important part of your patient's workup in premium IOL surgeries, and of course rule out any posterior segment pathology, because you may have done the best of surgery, chosen the best of the lens, but the outcomes will get compromised if you miss that. So what all do you ask a patient for? You have to ask a history of any chronic dry eye, especially autoimmune disorders which may be associated with ocular surface disease, with the impact the outcomes, any drug intake, especially if patients are on any kind of psychiatric drugs, because these press biopic IOLs have a time to adopt. So you should be aware of that. History of diabetes, and of course occupation, lifestyle. We've heard so much about how to plan what kind of lens depending on their visual requirement. One favorite point is the socioeconomic status when people talk about premium IOL, and I have not written and added that because over a period of time I've learned by experience that don't judge patients by how they look. They may be appearing as if they don't want to choose that lens for the cost factor, and later on after the surgery they may come around and tell you, doc, you didn't offer me the best of the lens. So give the option of premium IOL to all patients, and then it is their prerogative to choose or not to choose out of them. So we start with ocular surface diseases. So when you're on the slit lamp, start from the lid. Rule out any meibomian gland dysfunction. Look at the tear film. You know how to assess your tear films on the slit lamp. That's very important. Do not miss that, because again, I repeat that you may be using the best of lens, but if a patient has dry eye, irritating eyes, the tear film is the first refractive surface. So if that's not adequate and healthy, again, your visual outcomes will be compromised. So treat that first before getting your patient on to your biometries. First, treat any ocular surface. So you have various instrumentation, and I've put a list of things that you need to take care in the preoperative workup. And this is, I'll show you how it can affect the biometry. So this is one of our patients where when we first did the biometry, it was an acceptance of 21 was an E-metrope, but post dry eye treatment, you can see that there is one diopter of difference. So imagine he pays more, you do the best of lens, and he still has one diopter difference. Similarly, again, a patient before treatment of OSD, after treatment of OSD, you can see that the first biometry says that take a T5 model. Once you've treated him, the same person is accepting a T2 model. So this is just to emphasize that before doing your premium IOLs, even the biometry and deciding the power, treat their dry eye, treat their OSD. Now, how do you refine your current biometries? So optical biometry has made our life much more easier, but have optical biometry, please take out the immersion of your biometries. It gives you as accurate axial lens. You do not applanate your cornea, so you do not cause errors there. In your kerato reading, yes, you do need a topo, because just one keratometry reading is not enough, because then you're taking only anterior corneal curvature, and we know how important the posterior corneal curvature is. Get into account 50 of your cases. Just take your pre-op kerato and refraction. Do your post-op refraction and kerato. If you don't do the online tools to calculate SIA, personalized consonants, just give it to any of the top company peoples. They will do it for you, and you can have your own personalized formulas. So these are as many points you can make error in biometry, but the take home from this slide is spend more time, re-educate your optometrists again to spend more time on how to calculate and refine your biometries. Now, if you have an optical biometer, how many times have you checked the calibration? It's a must to do it weekly. For example, we have LensStar. It would not make you function till every Monday you have calibrated the machine. How many of us have looked at the head tilt? How many times the optometrist makes sure that the patient is sitting straight, especially in a busy OPD? There are enough studies and publications which say that even a 5 to 15 degree of patient's head tilt will affect the steep meridian of your axis when you're planning the toric lens. So here is a patient for demo's purpose. We've done the toric with the head tilt in the first picture, and you see the axis here is 72. We put the patient straight, meet the lateral canthus onto the machine, and you see the axis has changed to 82. So do go back home and tell your optometrist that please make sure that the head tilt is not there. Similarly, in acquisition, take out the outliers. For every single acquisition for your axis, axial length, kerato, pupil barycenter, there will be 5 readings. Out of them, if 1 or 2 is highlighted as being an outlier, you remove them and then you get your accurate reading with minimal standard deviation. It's important to be aware of angle alpha and kappa, especially for premium presbyopic lenses. So alpha is done only by eye trace. Most of us don't have that, but at least look at angle kappa, which is given by the pupil barycenter in most of the optical biometry machines. So initially, before few years, we didn't have optical biometry, but at least for our premium IOL patients, we used to send the patient next door to get one. So that's what you can do. If you don't own one, make friends with somebody who has an optical biometry. So this was the conventional way of doing the IOL formulas. Thankfully, we don't have to put our mind so much now with the advent of the Barrett suite, which is again online. So you can have your A-scan routine biometry, but do the immersion, take the kerato, use the topo readings, go online, put the readings, and you will be 99.99% correct without expensive machines. So these are the 2 platforms that you can go on and calculate your IOL powers. For toric IOLs, make sure that the steep axis is correct. First, you do your topo to rule out any kind of irregularity. Patient should not have keratoconus or irregularity. And why topo? Because there is a fixed assumption in the routine formulas on the anterior and posterior corneal curvature. But we know that posterior astigmatism by itself acts as a minor cylinder and either adds or subtracts to the width rule. So here is a case where the patient has almost the similar astigmatism. So you would think like a 0.86, 0.93, I'll have a small toric or non-toric. So in the width rule, you can see here that there's a non-toric and a similar kind of astigmatism. But against the rule, you've seen that the machine has told you to select a T3 simply because it's adding on to. So against the rule is A. I remember A for A. Against the rule adds on, and with the rule astigmatism, it kind of becomes lesser power. Now, we are always in a little flux when you see a 0.5 astigmatism, whether to do a routine spherical or should I go for toric. So you go on to the toric planner in your instrument, and it will tell you how and when you can modify your incision. So here is an example where there is a small astigmatism, and on the chart, the machine first tells me to pick up a T2 model, but I am manipulating my incision, and if I put it on the steep axis, I may also increase to 2.4. It becomes a non-toric model there. So this is also something which you can go back and look on the machines, how to plan your astigmatism in small amount of astigmatism. One word about the premium lenses in post-refractive patients, because the more LASIKs and PRKs out there, all of them are going to get old and get cataract. Not even old, I mean even younger people are coming to you post-refractive. So again, you can go online, and Barrett True-K is the formula that you choose. You don't even need the history and other previous details. If possible, if you can have access to Pentacam Holiday, it's good to look at this map, because then you can pick out the 4.5 millimeter, because here the anterior posterior curvature post-refractive is all altered. So the normal formulas don't work. So you can take the 4.5 and go online and feed this. It also tells you the X and Y plot, again to rule out angle kappas. So you wouldn't want to do in a large angle kappas any kind of presbyopic lenses, and it also gives you the mesopic pupil size. So all these are clues which help you to make your practice better. Now you've done all that and you've put these trifocals kind of lenses, and the patient still says that it could be either of these problems, and he will say, Doctor Sahab, kuch maza nahi aaya. And so what do you do so that he doesn't end up feeling that? So I don't like the word counseling, because we are not here to counsel. We are here to give them visual results also. So I say prepare the patients mentally, right? So talk to them, prepare them for all the outcomes, pros and cons. More expensive doesn't mean that each lens has its own little shortcomings also. And when you talk to the patient, you should make him sure that he understands that I am concerned about your outcome, your visual outcomes. It's not that extra cost which is coming with the premium lenses is my primary gain. So tell them that it decreases your dependence on glasses. Never use the word get rid of glasses. That's a very strong statement to commit for. Explain the technology, not so much about the lens and the company. Explain about your technique, your technology. I do it this way. Don't glorify the company. Glorify your skills. You've taken decades to reach where you are. It's very good to have digital source. Gone are the days of those printed brochures in the OPD. Like, you can put on as much stuff as you want on YouTube, on your website, and it's very important to give them a link. One, it's very easy for patient to wait in the OPD and just scroll through what is there on his phone. Two, whatever you want to be on social media and promote your eye clinic or website, every patient you give a link, while they are waiting, they just tap on it and read about the lenses that you have offered to them. So you're also increasing your web presence, and you don't have to go and hunt somebody for SEOs. When you're doing presbyopic lenses, tell them that it may take some time. Even when you go for new glasses or contact lenses, there is an adaptation time. So in the first and second week, the hell will not break loose if they have a little waxy vision or negative dysphotopsia from the side, because they are already informed. And in today's era, informed consent is very, very important. So if we have prepared the patient mentally, it's very important to prepare yourself also, because somewhere we are also stuck. When the patient is paying you a lakh, 1.5 lakh, you're scared. You just automatically take a back foot. So when you're well prepared, your confidence comes from within, when you know the machines, when you know about the technique. So prepare well, refine your technologies. Dr. Ritu's IC, more attend of her ICs and learn. Take feedbacks from people who are already doing those premium IOLs. Suppose there's a new entry, like there's so many Indian multifocals, trifocals coming now. You don't want to burn your fingers initially. Let other people create mistakes and then learn from their mistakes. Again, I would say that you are the best counselor for your patient. Extra 2 lines and 5 minutes with you will give him much more confidence than sending him to another room and saying that my counselor will explain. So this we have heard many a times in so many talks, that under promise and over deliver. And either ways, it's a journey. So enjoy that journey. And I think I've set the platform for the other speakers to come and explain to you more. Thank you.
Thank you, Dr. Parul. That was really an excellent talk. I think she's completed everything possible that one could want to do for a premium IOL workup. And one or two points that I would just like to add is, now that we've been doing so much of refractive surgery, always ask positively for a history of whether you've undergone refractive surgery. Many a time patients will not come forward and tell you, and sometimes you can even miss in your slit lamp examination. You may not be able to see it. A patient may have undergone PRK or even LASIK. You may not be able to see the flap. So always ask for your history. And the other thing we could do is higher order aberrations. Like if you have access to Pentacam and you're doing a premium IOL, it's a good idea just to get an idea of what the higher order aberrations pre-existing are. If they're already high, that patient may not be an ideal candidate for multifocals. So thank you so much, Dr. Parul, and please accumulate your questions and we can take them all in the end.